Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Welcome back. We are appropriately attired here to talk about sleep or a lack of. I am Dr. Christine Palmay, and I am joined by my friend, my colleague, superstar Dr. Jeffrey Habert. So Jeff, all about sleep today, huh?
Yeah, and you're wearing your pajamas, but in fact, this is what I would wear to sleep. The t-shirt, if it's really cold, the sweatshirt, and of course, my sleep cap. We always need a sleep cap.
A nightcap. You look very French-Canadian for our Quebec listeners if you exist.
Thank you very much.
And just to be fair, my pajamas are pink. They're not red.
You know, they look red. I don't know. I'm looking.
No.
They look red.
Well, regardless, we are actually taping this the eve before election day. So it's quite an exciting time. I hope that in two sleeps we'll wake up with a new leader and a unified Canada. So that's something to look forward to.
That's going to be a tough ask, but we won't get into that here.
No,
okay.
we won't.
Right.
So let's talk about insomnia. You know, a big war cry from our patients about sleep. And certainly, I think, there were a couple of diagnoses during COVID that just became common. And there's no doubt that insomnia was something that just skyrocketed in my practice during COVID. How about yourself?
Oh, no, totally. I mean, and it's funny because these new drugs, these new families of drugs came out at the same time. So all of a sudden we were once again talking about insomnia, or not once again. For the first time in our careers, we were really discussing it in a serious way.
Yeah, and I think that if you're just talking about statistics, about 40% of Canadians report insomnia symptoms, but very few talk to doctors and very few are properly treated. Now, they are likely treated. The abundance of over-the-counter insomnia aids, poorly used, everything from Benadryl to Gravel to alcohol to cannabis. So, people are definitely self-medicating, and you don't know what you don't know until you know. And I think if we actually ask our patients, we'd be surprised.
Right. And you comment on insomnia symptoms. So let's say the 25 to 40% report trouble sleeping at some point. But I think the more important number is that we're saying 10 to 15% actually have chronic insomnia, which is a DSM-5 diagnosis that can coexist with other DSM-5 diagnoses, whether it be generalized anxiety, depression, ADHD. And it's so important because we know what a lack of sleep, it affects every organ system in the body: cardiovascular disease, diabetes, cognitive function. Every single organ system in the body seems to be affected with people with chronic insomnia. And that magic number, it's interesting, it's like a U-curve, but like 7 to 8 hours is magic. And under 5 is when you start getting in trouble. But interestingly, over 9 or 9.5 similarly is not so great for you. Yeah. So you want to try and aim for 7 to 8.
And, I think I will get into treatment, but when treating insomnia, I'm actually less concerned about numbers to the T. And you have to think about quality of sleep too. What's happening during those 7, 8, 5 hours.
Restorative sleep, like real sleep, right? And people take a drug and they say, oh, wow, I slept well, but did they sleep well? Did we restore normal REM and non-REM sleep? And chronic insomnia is more about how they feel the next day function.
Yeah.
It's not about not sleeping per se, but people that don't sleep don't function well the next day. And we need to remember that. It's what's happening to them the next day.
I think reframing that, and you think about insomnia, you think a nighttime disorder, but really it's a disorder of the day. Exactly what you said, not being able to function. Parents need to drive their kids to school, showing up to work. The financial ramifications on it, on a wide scale economic level, personal level, people being at work but not really being present. I mean, that is a reality. I love that. So I think reframing it for patients and explaining it's less, what's happening during the night, but how you feel the next morning or how you don't feel and how you can function or don't function. Um, so let's go through a patient comes to you, known this patient for a long time. I'm just going to give a random phenotype. Let's say a male, 42. I'm only saying male because we did menopause last time, and we'll focus on males. Male, 42, has a career, has 2 kids, stable marriage, is really, really struggling for months on end, has increased his alcohol, and just finds that he's just not able to make it to the end of each day, barely makes it. Comes home from work, hardly has time to deal with his kids, and just flops into bed, and sort of the cycle repeats. How are we going to start the workup?
We know this guy, like you said. So first
Mm.
of all, we want to take a proper history and let's go back to the 9-minute visit. 9 minutes is a lot of time to sort out what's going on with him. So we find out first of all what he's been using, how he feels. Does he
Mm.
have chronic insomnia disorder? Like, has it existed for more than 3 months, 3 nights a week? That would
Mhm.
be a definition of chronic insomnia disorder. And is his sleep problem falling asleep? Sleep initiation? Is it staying asleep, sleep maintenance, or is it a combination of both? What has his response been and how does he feel the next day? I mean, so you're getting all that in the history. Then the comorbid stuff, the benefit of us as family doctors is we know our patients. We know about
Mm.
comorbid medical illnesses that can contribute. Let's take a quick look at the meds we're using. Are we contributing
Yeah.
to this? So are we giving him drugs that he shouldn't be taking that can mess up his sleep? I mean, simple things like decongestants that he may be taking over the counter. A simple thing like a salbutamol inhaler can be bad. Is he taking bupropion or Wellbutrin at night? Is he on a course of prednisone? There's all sorts of medications that can mess up his sleep. So,
Yeah.
and there are sleep indexes, but I'm going to keep it real because I think most of us probably aren't, and most primary care physicians aren't going to use an insomnia index, although one like the ISI is very helpful. It helps you with questions, but let's assume we're not. We've taken the history. We've determined that our patient has chronic insomnia disorder. He's been suffering like this for years. And as you mentioned, most of the patients don't tell us about it till they do. We now need to help them, right?
Absolutely, 100%. Right. And I think that, people or generally the medical community has been trepidatious to treat insomnia because many of the medications that we've had up until recently come with concerns, somnolence, problems with daytime functioning, addiction. So, I think that the other perspective is, and one of our colleagues, Dr. Kular, always says, would you ever not treat diabetes? Would you ever stop somebody's diabetes medications because it's been 3 months? And reframing insomnia as a chronic disorder that deserves chronic treatment is really the way to go.
I mean, absolutely. I mean, and traditionally in Canada, the most common, until the new family of drugs, which are called DORAs,
Hmm.
we'll talk about them, until they were available, let's say 4 or 5 years ago, the most commonly used drugs for sleep were Z drugs like Zopiclone or Imavane, an antidepressant, Trazodone. Some people were using Zolpidem or Sublinox, and some people are even using benzodiazepines like lorazepam, clonazepam. And we know, as you mentioned, these are all fraught with issues. They're fraught with next day somnolence. They're fraught with cognitive dysfunction, tolerance, addiction, nighttime falls and fractures, which is real. And we'll talk a bit about that if we have time. And
Yeah.
none of these drugs are actually in there. Some of them, not all of them are indicated for insomnia, but none of them are indicated more than 30 days. None of them. And we didn't
Yeah.
have a choice. So we all have patients that may be on Zopiclone for years. And I think now we want to try and convince people on why we want to change that behavior.
Yeah. Before we get into the details, I just want to backtrack and, trazodone always deserves a moment. I think
Absolutely.
most of us have patients on it.
Right.
And, I used to say to patients, or at least now I do, you may as well stick a tic tac up your nose, which I think I've used that phrase before here. And the reality is, for whatever it does in some of my patients' work, regardless of evidence, I think the main point, and we were just discussing this before we officially started taping is the safety of trazodone isn't what we've thought. The risk
No,
of
not at
falls.
all. I mean, not only that, I mean,
Mhm.
efficacy, I agree with you. We all have patients for which it works, but large trials suggest that it actually doesn't have great efficacy. But I think more important is what you said. It is not safer than a Z drug. So
Correct.
the fall and fracture risk with these drugs is significant. We need to keep that in mind. You're talking about fall rates that are, depending on what drug, that can be anywhere 30 to 50% higher, fracture rates similarly. And it's a big concern. You don't want our patients to sustain hip fractures, but Z drugs, benzodiazepines,
Yeah.
trazodone all have significant risk of falls and fractures. And trazodone's not better than the other two groups. And we've all been fooled over the years feeling that, a trazodone's a safer alternative. But in fact, we didn't have a lot of choice.
Correct. Correct. Well, that has since changed. So let's talk about this new class of insomnia medications and why I think, in my opinion, they are a game changer.
Yeah, game changer. I agree. I mean, they're called DORAs or
Mhm.
dual orexin receptor antagonists. And instead of sedating you, like hitting you over the head with a hammer,
Mhm.
these drugs block wakefulness. So I liken it to putting a white veil over you, so gently put you to sleep. But they do work differently because they don't sedate you. They block this wakefulness. And we believe a lot of people with insomnia have excessive wakefulness. It may not actually work the first night. It may take a couple of nights, and some people may take up to a week. So when we do use them, I always prescribe at least a month, and I say give
Yeah.
it time. There's two of them on the market now. We have lemborexant, which was the first one, or Dayvigo. We have daridorexant or QVVec, which was the second one.
Mhm.
So we have two new drugs, and every large guideline in the world advocates that they be used first line. And I'm one of the co-authors of the Canadian Insomnia consensus paper that we just published. And we say the same thing. The Americans say the same thing. The Europeans say the same thing. The Japanese say the same thing. But you know what? DORAs are a game changer, but I think we can't forget also about CBT-I because
Mhm.
we know that's
Yeah.
also first line. So CBT specifically for insomnia is very, very important. And it's not only about sleep hygiene, because in fact, sleep hygiene on its own doesn't work. Um, CBT-I incorporates 5 components, one of them being sleep hygiene, sleep restrictions, another one. And you can go to therapists to get CBT-I. There's all sorts of online apps, some free, some not. I like a website called mysleepwell.ca, which gives
Mhm.
you a list of all the CBT-I sites. So, I mean, definitely first line, but the one thing we've learned, offer CBT-I at the same time as pharmacotherapy.
Absolutely.
Our patients
100%.
have suffered long enough. They need help. This is a chronic disorder. I mean, these drugs are indicated for chronic insomnia. We're getting a lot more comfortable. I mean, I'm starting to use them for shorter periods also,
Yeah.
but they are both indicated for chronic insomnia. They're both safer. So we're not seeing tolerance. We're not seeing addiction. We're not seeing next day somnolence. We're not seeing an increase in fall risk. We're not seeing driving risk. I mean, the one thing it's interesting, because I never really knew this until I got into sleep stuff, is when you prescribe Zopiclone, you're supposed to tell your patients they can't drive for 12 hours. And
I yeah.
very few of us do that. Can you imagine telling your patient, yes, I'm going to give you a sleeping pill. You take it at 11 o'clock at night and it will help, but you can't drive till 11 o'clock the next day. So you might as well quit your job. Like, it's a tough sell when you're telling them that.
100%. And I think that applies to many of the other, sleeping medications that we were prescribing thus far. The rule of thumb with the DORA is, when I tell patients, I say, look, give yourself the possibility of 8 hours of sleep. Don't, may not get there. That sort of gives you a safety buffer, and obviously for medical legal purposes. But if we take our 40-year-old patient and make him 75, he's probably getting up to use the bathroom a few times a week.
Yeah, and I
And
think that's why
if,
these are a game
yeah,
changer because he's not going to fall. And we've
exactly.
shown that they're safer and that his risk of falling is a lot less. And I'm glad you mentioned that because we have data. Like we have data in patients up to the age of 88 with these drugs So they are definitely safe in the elderly. The drugs have been tested in patients with sleep apnea. So yes, it's a great point. And the elderly, as we age, we tend to have more problems sleeping. So I think it's important to keep that in mind that these drugs are also safe in the elderly.
Absolutely. So it also deserves a moment of switching. So, we've already said
Yeah,
these
that's a big
medications.
deal.
Yeah, these medications that we've had thus far are, effective because they hit you with a 2x4. But what are the consequences of that long term, short term? So, how are we counseling our patients and what are you doing in terms of switching?
Okay, so you know what? We learned early on what not to do. So
Yeah.
early on, we got all excited. Our patients on Zopiclone and Trazodone, we were saying, "Hey, Bob, we got a great new drug. Stop your Zopiclone. We're going to put you on this new drug." That does not work.
Mhm.
So we have learned. So we do a crossover type thing. So let's give you an example. The patient's on Zopiclone 7.5. I actually introduced the DORA at full dose. Like
Yeah.
if I'm using lemborexin 5 milligrams, if I'm using a daridorexin 50 milligrams, and I keep the full dose of Zopiclone for month one. So month one, Zopiclone 7.5 plus Dayvigo 5, let's say. Month two, we cut the Zopiclone in half and we either continue Dayvigo at 5 or increasing it to 10 or QVVEC at 50. The interesting thing is this. So I've cut the Zopiclone to half. In my practice, I'm finding about 20% of people will need to stay on a low dose of Zopiclone 2.5 or 3.75, which is fine. It's harm
Yeah.
reduction. It's a much lower dose. But what's most interesting, and I suggest physicians ask their patients, we know that a drug like Zopiclone or Trazodone do not work long term. They develop tolerance.
Yes,
So what
exactly.
these people do is they're starting to take over-the-counter drugs anyway.
Yeah.
So
Yeah.
my Imavane patient is taking Imavane, melatonin, Benadryl and falling during the night. So if I can get him down to 2.5 of Zopiclone alone with my full dose Dora, I've had significant harm reduction. I reduce their risk of falling. I reduce next
Mhm.
day somnolence. I restore normal sleep. But the majority of my patients, by crossing over, I can get them off the Zopiclone and the Trazodone.
I
You
mean, I think
notice I didn't mention
yeah.
benzos. That's a whole different story, right?
Well, benzos, I mean, I have, 80-year-olds that have been on benzos for 40 years. Like, good luck with them. But like you said, harm reduction. And I think that, as physicians, we're always aiming for perfect. And I think reframing it that, you may not get to zero of Imavane. You may not get to zero of Ativan. In fact, I
Right.
suspect you
And,
won't.
and
If you get half or a quarter, then that's
that's a win. And the
exactly.
other thing we got to remember, and I know, Christine, we've talked about this, is all our patients with other DSM-5 diagnoses like depression and anxiety, a significant amount of them suffer from insomnia.
Yeah,
Treat them both. Treating the depression will help the insomnia.
absolutely.
Treating the insomnia will help the depression. Treat them both. It's very important.
Absolutely. And, I often, when I'm speaking to patients, say with a new depression diagnosis or anxiety diagnosis, I mentioned insomnia, I'm like, what are we going after first? Prioritize what you want. Sometimes I attack the insomnia first, but usually there has to be, you have to respect both conditions independently. Completely agree with that.
And, and I mean, before we sign off, I think we need to think of insomnia as a chronic disorder like all the other chronic disorders we treat. And I always say that treating sleep properly improves not only just their rest, it improves their life. Like
Absolutely.
it's a life-changing thing to help patients sleep properly.
100%. And, a patient, I certainly had a patient who I prescribed a Dora to, and he unsolicited called the office 2 weeks later and said, my life has completely changed after 2 weeks. And very rarely do you get that, impromptu feedback. Certainly patients will call to complain, but a happy patient generally doesn't call and say thank you. And in this case,
I
it
agree.
was. So I mean, a really, really big impact.
I mean, I think before we sign off, though, let's be transparent that DORAs do not work in all patients.
Hmm?
So, I mean, there are patients where they don't work and we need to look for other things. Have we looked for other sleep disorders, restless leg? Do they have obstructive sleep apnea? Do they have periodic
Correct.
leg movements? I mean, always think of other diagnoses. And is it 100%? No, but it works in a significant amount of patients. And we got to be patient with this. We need to tell our patients to be patient and always give it time, because I think if it gives it time, we'll get success a lot more than the patient that stops after 4 or 5 nights because it didn't work.
Absolutely. So on that note, we're going to sign off and say
go to
good
sleep.
night, sweet dreams, and see you next time.
Have a good one. Thank you.